So those last talks we saw just show some of the real value, I think, of peer-based support in the integrated services. And peer-based support is a key expectation for integrated services after the Royal Commission. So this talk is about the challenges we actually faced at our services in integrating the peer and the clinical workforce, particularly earlier on in our service life cycle. So just want to tell you about some of the elements of the services design we had early on, which were aimed at integrating the peer and the clinical workforce. So in our local services, initially we had a 50-50 split of peer and clinical staff. We had joint leadership structures, so on the front line we had peer leads and clinical leads, and then at the service manager level we had both peer and clinical service managers. In terms of our workflows, we had peers responsible for both consumer entry and exit to the service. So the aim of that was to create a safe and welcoming entry point and then a smooth transition out of the service. And we had two-person care teams of the peer and a clinician, and the aim was to bring the best of the peer perspective and the clinical perspective to people's care and support. But as we saw in the talk I gave earlier, those formal elements of our service, they don't always play out on the ground as we would expect. And so in the work, we were not only interested in integration between mental health and AOD staff, we were also interested in integration between peer and clinical staff. So that's our We'll See Advice network that I showed you earlier, but this time I've coloured our staff by their peer or their clinical roles. So we've got clinicians are our green circles, peer support workers are our orange circles, our peer leads are the orange squares, and our clinical leads are the green squares. So those leads are the more experienced peers and clinicians who have formal leadership responsibility. And one thing you can probably see, we probably would have noticed from these network maps, is they're really messy, right? There's lots of people there. There's about 60 people there and hundreds of relationships. So it's really complicated. There's only so much we can actually tell by mapping these networks. We actually have to use statistical analyses to understand some of that complexity. So one thing we can do is, instead of looking at all the people and all the relationships, we can shrink our network down and we can look at the connections between different roles. So in this network map, we've got our different clinical and peer roles in the service, and the arrows from one role to another represent the amount of advice seeking from that role to the other role. And so there's a green arrow if there's more advice seeking than we would expect from one role to another role. There's a red arrow if there's less advice seeking than we would expect, and the thickness of the arrow is proportional to the amount of advice seeking. And for anyone who kind of has a statistics background or is a statistics nerd, that analysis is based on a network equivalent of a chi-squared test. I won't say anything more about that. But the one thing we can see here is, if we look at our clinicians and peers, this was the first survey I did in the middle of last year, you can see that our peer support workers are going to our clinicians for advice about as much as we'd expect. So that looks pretty good. But when we look vice versa, our clinical staff are only going to our peer staff about half as much as we'd expect. So there's less advice seeking there than maybe we'd like. And for an integrated service where we want to really elevate that peer voice, maybe that's problematic. So we were kind of interested in understanding a bit more about what was going on here in peer and clinician collaboration. And that network analysis was reflected in some of our staff experiences of the service. I would just to highlight that kind of indicates this kind of inequality, right? There's more advice seeking to the clinical roles than back to the peer roles. And so there's this kind of informal hierarchy going on. And so in some interviews I did with our staff, that informal hierarchy was kind of experienced in the service. So this clinician told us a lot of the challenges come not from the peer workers, but from the way the service is set up. There's all of these differences in the roles that can maybe lead to the peer workers feeling less valued, or that they have less power or control in the work. So what's interesting about that, right, is the clinician is talking about service design. They're talking about how the setup of the service shapes that interpersonal collaboration across those roles. A peer worker told me, in my experience, it seems to be only the peers that are pulled aside and reprimanded by leadership. And a lot of the clinicians talk about how they've got so much more freedom. Now, this peer is experiencing that inequality in a really personal way, right? They're talking about their personal relationships. And so we wanted to understand, first of all, more about what was going on in this unequal collaboration, but more importantly, how could we actually intervene and try to improve it? And so I want to hand over to Caitlin, who's our peer practice lead, and she's going to talk through kind of what we did next.
All right. So I'm going to take us through the methodology. So we started with some pretty standard research tools, one-on-one interviews, surveys, and then a network analysis. And as James mentioned, the one-on-one interviews suggested that these themes maybe needed closer examination, and the network analysis then confirmed them. And these findings led us to want to work directly with the teams. But we needed a thoughtful approach as the issues are complex, sensitive, and tied to people's identity, experiences, and roles. So I'm going to talk through now how we designed these workshops, the methods we used, and why we chose them. As mentioned, the network analysis identified barriers in two-way knowledge sharing, which I'm sure isn't surprising. Our workshops were focused on uncovering the dynamics beneath the data. We combined action research with relational approaches, researching with teams, not on them, learning alongside participants, and adjusting where we needed in real time. We wanted to create reflective spaces where people could notice themes and consider what they could influence. Rather than just staying focused on barriers, we also invited participants to explore possibilities, how diverse perspectives could be respected, and how teams might work together in new ways. Therefore, we intentionally elevated lived expertise and used dialogical practices to reduce hierarchies and create the conditions for more equitable and honest conversations. We designed the content of the workshops in ways where participants could unpack difficult questions, hear honest reflections, and explore assumptions and tensions with care. We wanted participants to feel psychologically safe enough to be able to stay engaged even when it felt uncomfortable. To support this, we shared a code of care with everyone before the sessions. Now, I intentionally say safe enough and not safe, because safety is personal, informed by experience and identity, and we can't say what is safe for someone else. Safe enough acknowledges that some risk and discomfort are part of the process of learning, growing, and working together. We encouraged people into the stretch zone. In the workshops and throughout this project, we've drawn on intentional peer support principles and practices, as I'm an intentional peer support trainer. And IPS centers mutuality, curiosity, and connection. It asks, what if we're both experts in different ways? We also brought in Vicki Reynolds' wisdom on group supervision and used dialogical formats like fishbowls and small group spaces to deepen reflection, encouraging participants to learn to listen differently and let meaning unfold through dialogue. The workshops, Sorry, folks. The workshops ran over a week in March this year. We knew the structure of the workshops could either hinder or support psychological safety, so we began the series with discipline-specific groups, presenting the network findings to clinicians and peer workers separately. In these separate sessions, clinicians considered what made them hesitant to seek advice from peer workers, and peer workers reflected on the barriers to sharing their perspectives. Separating the discussions helped depersonalize feedback and allowed people to express what they might not say in front of each other. After day one, the three facilitators reviewed the outputs and adapted the next day's session in response. When we brought the groups together on day 3, we used a dialogical technique called a fishbowl. The three of us openly reflected on our experiences from the first day while the participants listened. This allowed everyone to hear the perspectives, tensions, and insights that had surfaced in the separate groups before engaging with each other directly. We also created 2 one-page tools for people to use in their work into the workshop and take back to their teams. We had a collaboration competencies sheet which described practical skills such as active listening, staying curious, owning impact, and checking assumptions, each with a brief workplace example. We also created a bias tool which named common patterns with reflection questions such as who do you naturally turn to for advice, and where does your idea of expertise come from, to help participants notice what influences their decisions and interactions with each other. We also definitely didn't smooth over the ongoing challenges faced by lived experience, AOD, LGBTQIA+, disability, First Nations, and multicultural communities and workforces. Things like discrimination, power imbalances, and undervaluing of our ways of knowing. We didn't want to shame or blame, but bring into the open what is often still unsaid. If we stay silent, dominant perspectives continue to keep being reinforced. So, during the workshop, participants mapped barriers, explored told and untold stories, and looked at how different disciplines approached the shared work. We anticipated that systemic issues would inevitably come up, so we separated challenges into two categories: what's within the participants' influence and wider system challenges. Participants could then focus on what they could act on directly without feeling like the broader context was being ignored. After the final workshop, one of the participants reflected that the process was confronting but necessary. And I think this captures the essence of what we hoped for: spaces that stretched, invited honest reflection, and gave something practical and hopefully hopeful to take back into their work. As a final point on methodology, our collaboration, the three of us, mirrors what we were asking of participants. We work across different disciplines, so occupational therapy, academic research, and lived experience, and we practice power sharing, openness to each other's perspectives. Priscilla will now take us through some of the workshop findings.
Thanks, Caitlin. All right. So we've got two main findings, and so the first one is about what we came to understand about the barriers and the challenges for two-way knowledge sharing, and then onto the possibilities for strengthening two-way knowledge sharing in collaboration. What? Okay. So in the first workshops, where peers and clinicians were separated, we explored the barriers. Clinicians initially focused on more structural barriers, like the design of roles, workflows, and hierarchies. They talked, for example, about the impact of shift work, limiting their connection with others. They described how there is more protected time for clinicians to be together than there is for clinicians and peers to collaborate. Some acknowledge not understanding the peer role, and they describe not having time to share information effectively. Whereas for peers, they initially focused more on interpersonal barriers. They felt that clinicians were not curious about peers' lived experience, and peers wanted to be known. They described clinician assumptions of a single right answer and how this can override peer perspectives. And they talked about hierarchies and favouritism by management, managers having different expectations for different groups of staff. And we wondered together if these starting points to barriers made sense because of what peers and clinicians are more familiar with. Clinicians may be more familiar with institutional structures through their training and their experience. They are known and expected ways of working, while peers prioritise relationships as their starting point and are possibly more cautious of structures due to being on the negative end of experiences. However, we were interested to see that both groups, given a safe enough space, came to raise many common barriers. Both groups moved on to talking about practice knowledge, role clarity, and consistency of practice. They described uncertainty around their practice. Peers wondered if clinicians could shift their practice from being diagnostically driven to guest-led, and clinicians felt the peer scope of practice was unclear. Both described uncertainty about navigating safety and risk, and both focused on their own fears and insecurities. Issues you might assume were more of a challenge to one or other discipline, they were actually frequently shared. For example, many staff talked about feeling not confident in their roles. Clinicians described the pressure of being the expert, with other staff coming to them for advice, but not always feeling they had the answers. And peers described lacking confidence in their role in the work process. Clinicians wondered if and how to disclose lived experience to other staff, and peers wondered about sharing their diverse experiences, for example, of AOD use. Peers assumed that clinicians were avoiding collaboration because they worried about a peer's ability to manage their emotions, to cope. And both groups felt awkward navigating tasks. They were thinking, can I ask them to do that? Should they be asking me to do this? So there was a lot of this questioning going on, but not much opportunity in the service to unpack these questions openly. And for us, this reinforced the need to go beyond assumptions based on roles or typical structures and hierarchies. In the second joint workshop, when barriers were anonymised and reflected back to the combined group of peers and clinicians, we noticed a shift. Depersonalising the barriers enabled this. It was here that we could start to see the research was having the intended impact as a kind of intervention. Feelings were expressed. For example, there was a sense of discomfort and sadness. They said, it's actually quite overwhelmingly sad that as a group of 60-something people, we're all feeling quite uncomfortable at work constantly. And some hard realisations, like we know each other's pets better than we know each other. And then there was this relief and recognition of this shared experience, shared fears. And this shifted the discussion from othering, from us and them conversations to expressions like, yay, we're just all feeling insecure, and acknowledging how hard it is to say, I don't know. And there was this recognition seemed to allow a reset. There was recognition that we're all in this together, and while there are many differences, there are also many similarities. This shift allowed the group to think rapidly and constructively about ways to address the barriers, which I will talk to in a moment. But first, what does this tell us about service design and designing for integration, especially when we were designing for something new, different, and better, not simply trying to integrate a newer workforce into a traditional model? We need to recognise that there is a lot going on in every unique interaction between a peer and a clinician. There are potential barriers at every level, and these interact in complex ways. At the interpersonal level, there are different starting points and familiarities, assumptions based on role, different experiences that are not always shared, and differences in preferred ways of working. But these don't emerge or exist in a vacuum. They are nested within efforts to negotiate a shared approach to practice, how to bring together and harness the most relevant set of knowledge, skills, and experience for the benefit of any particular consumer. And that is nested within the service structures, how roles are set up, how hierarchies are structured and challenged, how workflows are constructed and work is allocated, how meetings and other spaces are run. So, while two-way knowledge sharing between peers and clinicians might seem simple, this shows it's not simple at all. What a peer is prepared to share with a clinician, or vice versa, is going to be influenced by the way workflows are set up and how hierarchies are navigated in team meetings. The way that practice is negotiated between staff will be informed by the degree to which a peer or a clinician is curious about the expertise of the other. Is that understanding founded only on role-based assumptions, or is it founded on knowing the other person and valuing their diverse experiences and worldview? This tells us that we are unlikely to generate solutions to two-way knowledge sharing or collaboration by only looking at one layer in isolation. We need to think in an integrated way about service design beyond just grouping staff with different roles. We need to build in scaffolding to support relational practice at each layer. When given the opportunity, participants came up with a range of ways to do this in the second session. For example, at the interpersonal level, there was strong recognition of the value of knowing each other better. One solution generated was the idea of collaboration kick-off meetings. A peer and a clinician meet together before meeting a guest to think about what expertise they each bring and how they will harness it for the benefit of the guest. In relation to building a shared approach to practice, they wanted facilitated sessions to reflect on their practice together. They wanted spaces to feel uncomfortable and to move from assumptions to curiosity. And I think we need to get better at building capacity for this facilitation. And at the level of service design, designing meeting structures and decision-making processes that provide a framework for more equal knowledge sharing is important. We found that by understanding the barriers from separate and then shared perspectives, we were able to generate solutions that will enhance two-way knowledge sharing, and these can now be designed into the services themselves. And we can test them and see if they deliver the more integrated support and better outcomes for people as anticipated. Our work reinforces that integrated support does not occur by putting peers and clinicians together and encouraging them just to work it out. Effective knowledge sharing, collaboration and integration will not occur without appropriate support, scaffolding, structure and time. While it is tempting to situate all collaboration challenges at an interpersonal level, to imagine it is all about the people involved, or to assume that teams involving 50-50 clinicians and peers can't work, we actually need to think about all the layers and their interactions. We identified levers to scaffold collaboration at every layer, valuing this activity as part of the work, even though it's not always direct service delivery, and making ongoing time for it and designing it into services feels essential to achieving the potential of these teams so that they can deliver consumer outcomes based on genuinely integrated support. Thank you.
Hi everyone. That was meaty, wasn't it? There was a lot in that. I was thoroughly enjoying that, and congrats to the team at Neami, because that is some really powerful and critical work in this space, because those of us trying to do this work know how challenging we're finding it. I'm not about to launch, when I say this, it sounds like I'm about to launch into a long thing, but I'll keep it good. I've been reading a book recently called The Four Pivots, which is about social justice, human rights change. And one of the concepts talked about in that was really coming up for me listening to that presentation, which is the need to move from the lens space to the mirror, which is to move out of the analytical, trying to think our way through change, and into the deep human feeling space of asking, what am I bringing to this? And how am I contributing to this dynamic? And that's really difficult stuff to do, because it requires a lot of ownership and it requires stepping into the messy. But I think that's what we really heard here. We do need to look at the systems that sit around peer workers and clinicians, and that really came through, so that it's not just about looking at the different practice, but looking at the decision-making models and how you conduct meetings and how you think through the frameworks that guide the work that you do. And I think that's really powerful. And also, equally, the authorisation. So how do we enable different people and different levels and different disciplines to be part of holding the ultimate kind of decisions? Because I think that helps us to think really deeply about the work that we do. I think that was probably about, some questions I had was around how do we move from services doing this work, where we were often able to have more influence, into higher kind of structural change, and what does that mean for the organisations we work in and the system at large. And also that we have to, I think that we're so often trying to show how tidy we are in the work that we do, and that it's going to be effective, and that we've got I won't swear. We've got our stuff together. I'm searching. We've got our stuff together, and that we're not going to make a mistake. But actually, to achieve really meaningful change, we have to sit in the messy and the uncertainty and the not knowing and the being vulnerable and the showing up in that. And that's, I think, an opportunity for all of us, and it's deep relational work. It's something peer work has to offer, but I think it's also just very broadly human. So congratulations. It's really interesting.
There'll be a paper.
Excellent.